Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Wiliams. Paul, how are you feeling about sports injuries?
I'm feeling great, Matt.
Well, Paul, you had a sports injury of the hip, and that was part of why we wanted to do this episode. Maybe that's an overshare, Paul, but we talk about it on the episodes.
I think I've shared more than my hip injury for sure.
Yeah. So, Paul, when someone has hip pain, I used to just pray it was like trochanteric bursitis, which now I know and we'll talk about is not really the right thing to think about at all. But if someone has intra-articular hip pain, that's going to present as anterior hip pain, usually in the crease of the hip. And the differential for that, our great guest, Dr. Carlin Senter, gave us, it could be an iliopsoas tendonitis, right? Because that's coming down and inserting in that area. So that's one thing it could be. It could also be femoral acetabular impingement syndrome. It could be a labral tear. It could be a bone stress injury of the femoral neck, or it could be osteoarthritis. So depending on the patient's age and the story that you're getting, those should be some things that are on your mind. And we'll go through a little bit about how to differentiate them, Paul. So for FAI, what exactly is that and how might we diagnose it?
So yeah, FAI is what the cool kids are calling femoral acetabular impingement. And so basically what this is exactly what it sounds like, Matt. There's something pinching or impinging upon within the joint itself, preventing sort of full range of motion. It's a ball and socket joint, as you know, so it should have tremendous sort of range of motion and can move in all planes. But if it's impinged, then you will have pain with certain movements. There's a CAM type, which is characterized by enlargement of the femoral head-neck junction, or a pincer type, which has more to do with the overhang of the acetabulum, and oftentimes it can be mixed. But in any case, the configuration of the hip is such that there is a pinching or impingement upon your full range of motion that would then result in pain. And the way that you evaluate this is with tests that you do and there's the FABER and the FADIR test, though I don't think I knew FADIR had a name. But anyway, there's flexion, abduction, and external rotation, or flexion, adduction, and internal rotation. And if you elicit anterior pain with those, it means it's probably one of those intra-articular pathologies, though it is hard to know for sure which one it is, because it's a really sensitive test, but also not a very specific test.
So you can get the x-rays, right, to help. And so the two views of the hip that you would get, there's the one view is the AP of the pelvis, where it's just a straight-on shot, where you're looking for arthritis, you're looking for fracture, is there a healthy joint line there? And then there's the done view, which is the hip is flexed at 90 degrees and abducted about 20 degrees. And you're looking there, again, for fracture, you're looking for impingement. And you can diagnose FAI based on that. You might be able to diagnose a hip stress injury based on that. And, of course, osteoarthritis. So all those things can be helpful. Labral tear, unfortunately, you're not going to see that there. But she makes the point, FAI and labral tears are pretty much treated the same way with physical therapy. Patients who aren't getting better, if they have FAI, might end up going for surgery. And at some point you might, I would refer them to orthopedic surgery. But, I would feel much more comfortable now diagnosing these with the tests you talked about, Paul. Let's talk a little bit about this trochanteric pain syndrome, Paul. I mentioned that I used to think it was all a bursitis. Why is that not correct?
Oh, Matt, you sweet fool. It's nice of you to feign ignorance for the purpose of education. But yeah, it used to be thought of bursitis. It used to be thought to actually involve the bursa, but these days we know it is probably more likely a tendinopathy, and this is based on MRI studies and various research that's been done. So it's a tendinopathy of the surrounding structures. This can include things like the gluteal tendons, the IT band, the tensor fasciae latae, and we have a great infographic that sort of shows the face of a clock and how those things relate anatomically. It's kind of hard to explain out loud, so I'll let you look at that at your leisure. But in general, you manage this, frankly, the same way you did with the bursitis, well, we called it that, which is physical therapy, and you can do corticosteroid injections too. The physical therapy is probably more durable in terms of pain relief and functionality, but in the short term, corticosteroids might provide some degree of analgesia as well. So that is our trochanteric pain syndrome, formerly known as trochanteric bursitis, but probably the bursa is not involved that much at all.
I knew that it wasn't a bursitis, from previous episodes, but that it was a tendinopathy. That still shocks me. The last thing we wanted to mention is this bone stress injury, which can occur in people who are just doing high mileage, so runners who are doing 20 miles or more per week. That's something that they can get. And if someone does have a bone stress injury, they need to rest, usually non-weight bearing for a period of time. If they actually have a bone stress fracture, depending on which side it's on, if it's on the top side of the femoral neck, which is the tension side, it has to be fixed. If it's on the compression side, which is the bottom side of the femoral neck, then it might be able to be managed conservatively, but a lot of patients are going to need surgery for this one. So this is a big deal if it happens. They can also just have, I guess it's a spectrum, Paul, so maybe the bone can be very irritated and unhappy, but not have a break in the cortex, and in that case, they might not need a surgery to fix it. But she also mentioned that in patients who do have a fracture of the femoral neck, especially younger, healthier patients, you should think about getting a bone density test in them, and you should really screen for this relative energy deficiency in sport. They used to, I believe, call this like the female athlete triad, where they were having, disrupted menstrual cycles, or underweight and fracture. We should be screening patients, asking them in a non-judgmental way, like, what is your relationship to food, making sure that they're getting the appropriate number of calories, because some athletes are so active, they're actually in an energy deficit. They're not eating enough to maintain a healthy body as they're doing all this activity. Anything else about the stress fracture or relative energy deficiency in sport that you wanted to highlight, Paul?
No, I think that's a nice overview. I think if you're interested and this sounds appealing to you, you should refer to the full episode, which I thought was chock full of helpful information.
So, of course, you can click on the link in the transcript below. And with all that, I have been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Well, maybe your brain hole, Matt. And as always, our main Dr. Carlin Senter, Wiliams, thank you, and goodbye.